Yeah, okay, thank you so much. It was the first point to consider both eyes, not one eye. The second point, to consider the clinical correlation. The paper does not expre- are not ex- the papers are not expressing the patient's status alone. So it's not logic to judge the patient with just some papers. You have to correlate the clinical data together with the data obtained by the investigating machines. If you have any abnormality, you have to recheck again. If you are not sure about the clarity of the cornea, you have to check it again. Maybe faint opacities, which may be missed during your examination, will explain the irregularity in the anterior surface curvature or in the pachymetry displacement thinnest point. So don't forget that you are a clinician and a surgeon. At the same time, you are not just a technician with the papers printed out. No financial interest. So we are talking about risk assessment today with this device. The basic knowledge is the new advanced tools regarding the increasing the sensitivity of the devices, and all of them are serving us to avoid the nightmare of the refractive surgeries, which is the ectasia. And all these tools are available today to increase your safety profile and make you more confident and comfortable about your judge. I got it again to emphasize on this point. Finally, you will get the conclusion from all these tools that this patient is normal, and there is no patient which is completely normal, but maybe within the normal range regarding this device. Nobody is immune from the complication regarding the ectasia after that, but what we are saying all the time, we are doing our best to avoid or abnormal or the gray zone, which is the innocent patient or innocent papers, but still rejected. Okay, I mentioned all these slides before. I covered it. So the topography techniques, either by the reflection-based techniques like in gravimetry, or the projection-based techniques in the stereography or interferometry. The placebo disc is a projection-based, which is based upon the phenomena of the Purkinje image. And so the corneal topography by name, as I told you before, the placebo disc in the refractive surgery corneas, the post-refractive surgery evaluation, the post-operative astigmatism regarding the surface irregularities, in the post-plasty, post-cataract, ocular corneal surface disorders such as dry eye, pterygium, corneal scars, and nodules. Other uses as a fitting of the contact lens regarding the cornea, either regular or irregular, like in the rigid gas permeable and scleral fitting of scleral contact lens fitting. Also, the corneal wavefront will give you an idea about the high order aberrations. Especially in the MS-39 nowadays, we have a separated epithelial wavefront analysis than the total corneal. So we can separate both because it's OCT based. We can separate the epithelial or the surface related with high order aberrations and also the total corneal, either epithelial or total corneal. Also the elevation, the maps regarding the anterior surface, the axial or tangential anterior curvature maps, also the elevation maps calculated from the anterior curvature maps, refractive power map, and tear breakup time display, which will give you an idea about the wetting status of the surface, either dry or accepted. Kertoscopy in the past was this handheld desk with these mirrors, which are increased nowadays up to 25 or more in the newer devices in the video kertoscopy. I don't like to waste the time in this theoretical information. I think everybody knows it. And I believe finally that the Placido desk topography is the most reliable and accurate sensitive one, but it's hard to be obtained if there's an abnormal corneal epithelium. It's drastically affected by the tear film. So the most recent one is the MS39 because it has two advantages. The first one, Placido desk topography and OCT-based tomography, including, so the intercurvature map is obtained in the MS39 by both direct topographer and the calculated intercurvature map from the tomography data. The slit scanning is the ARP scan and the well-covered pentacam by Dr. Ihab. So simply, this table is summarizing the difference between the topography, the elevation-based, and OCT-based tomographies. And you can capture it if you want to review it after that, but you will find here that there is a central blind spot. It's in the topographers, but not in the tomographers. So the tomography will cover all of it, all of the surface, because it's actually in direct calculation. But the direct topographer will miss the central part, which is coincident to the fixation point. But you will find that the OCT will cover more surface, wider surface, and deeper studying for the cornea. And at the end, you will find that the speed of the capturing will be fast in the topography, but it's a little bit slower in the elevation-based and very fast in the OCT. So I could have MS39 capture for a baby of 3.5 years old. Because it's very fast. In a part of a second, it will give you an idea about the old data needed for the cornea. The high-resolution corneal section, it's not in the topography, as I told you, preliminary in the elevation-based, but it's very high. It is with very high resolution in the OCT-based because it's the spectral domain high-resolution OCT actually. So the overview, and I bought this image to show something. It's a total photo for the speakers in this conference, but finally I studied it very meticulously to find my photo in between. So this is the idea of studying the pentacam or the topography and tomography. Get a quick look to get a general or overview or an idea about this print, and then recheck every point separately and meticulously again, then correlate all of them to each other. How to read the corneal topography? You have to be a good judge, a very focusing judge, not to be crazy or panic and scared like that. And there are the general instructions on capturing the image. It's well covered by Dr. Ihab, and I will increase the last line. Please don't forget to ask about the contact lens wearing, and put in your consideration that the women are usually denying the contact lens wearing. I don't know why, but many times I found that there is some irregularities in the surface. But when I asked about the contact lens, were they? No, at all. 1 month ago, I didn't put it on, but finally I found that she was coming to the center with a contact lens. Just removed it 30 minutes or 1 hour before the capture. I don't know why, but it may be because they were told about that I will postpone the surgery if I knew that she had the contact lens on in this time. 5 minutes? 7? كان في وقت وضل ضايع في الأول. Okay, just a minute. And so because of the sake of time, I have to jump. Interpretation of the tomography printout, a stepwise approach here will be useful in interpretation. 15 points to check. Correctly identify the patient to be him or herself, the eye, as well as the acquisition reliability, which is the qualification or the QS. The standard, the qualification standard. Same device setting should be adjusted based upon the international guidelines. Review the setting of the device to know about. Third point, check the geometrical measurements of the cornea, like the Q value and the angles. Angle alpha, angle kappa. You have to review all of these. Q value first, to know about the slope, to know about the acquisition, and so. Don't forget the clinical data and also the angle kappa. If you find it's large, it may be misalignment or actually true large angle kappa. Don't forget the clinical data, as I told you before. Start by looking at the multi-map option and then every map in single interpretation. Look at the pseudo-color scale to identify the range and the gradient of the values given. Start to look at the actual numbers and charts in the statistics boxes. Then check every map meticulously and systematically. Finally, give your patient a score. How many from 10? If 9 out of 10, it will be okay and may pass. Less than, you have to think again and let's go. This is the international guidelines about the radius of curvature, about the axis of the astigmatism, and the Q values firstly in the elevation maps, covering the central 6 millimeter in the Q value, but in 8 millimeter in the elevation maps. Color scale setting, either normalized or absolute. The color coding on the American style. It's commonly used, the American style color coding. And let's see here, these boxes. The name, age, the quality specification, which is expressed in the QS, is okay or accepted, like in this yellow triangle. If red, no, don't accept. And the Q value, the central 6 millimeter for both front and back surfaces should be less than -1. If more than -1, either improper capture or abnormal cornea. The key reading Q1, Q2, key mean, CMK, which is the same like key M, and finally the key max. And you know the relation between the steep K and the key max, and should be the same or the difference shouldn't exceed 1 diopter, and should be correlated with the thinnest location point, the thinnest point location. If the key max is not with the same with the thinnest point location, it will be negligible. Step 5, the multi-map or the composite map. The 4 composite map in the all devices, but here in the MS, we have 6 composite map with these 2 extra maps, the posterior curvature map and the epithelial thickness mapping, which is with which is of very great role in detection of the early keratoconus or to exclude the keratoconus as well. Finally, the anterior curvature map, as I told you, either by the topography or by the tomography. It's named the anterior curvature map. What to check in the anterior curvature map? The central 3 millimeter, then the central 5, then the central 7 or 8. Starting from the central part of the cornea, the 3 millimeter should be very sensitive and should be very meticulous. It's not allowed in the central 3 millimeter to find the difference between the superior and the inferior points. And the inferior, higher points, is more important than the superior in the central 5, but it's still important in the central 3 millimeter. According to the find we have found in our practice, the central 3, the superior and the inferior point should be almost the same. But if the superior point is higher than the inferior point with more than 0.5, you have to focus on it to find other pathology in the other map, or to explain either pressure by the eyelid during the capture or by scar in this central part of the cornea. But it's not like the central 5. You know that if there is steepening in the superior part in the central 5 millimeter, which the point superior is steeper than the point inferior, it could be because of the pannus, tight lid, pulling of tears, or other, which may be explained clinically. But if the inferior part is steeper than the superior, you have to think again about this point to find an explaining finding in the pachymetry map, on the back elevation maps, on the back curvature map. Otherwise, you will ask for the epithelial mapping, finally, to know if there is a thick epithelium above this point, it's just epithelial hyperplasia. But if the epithelium thickness is thinner on this point, thinner than the superior, it may lead you to think about an early case of keratoconus. I'm trying to be fast because Dr. Rahab is looking at me. So here, to use in the anterior curvature map, axial or tangential. Axial is with larger sized images, central more than peripheral, but with wide gaps, wide foots, okay? So it's more beneficial in the biometry than in the refractive surgery regarding the laser-based refractive surgery. So we like, or we prefer to use the tangential map because it's more meticulous and it's studying more points and closer points of scanning on the surface. So tangential anterior curvature map is more accurate than the axial curvature map. And also it's studying a wider part of the anterior surface. So it's more accurate and more trustable. And as you see here in the photos on the side, there's a difference between the anterior curvature map. Look, the color coding is more friendly than the tangential curvature map because it's with narrower and smaller zones. The second point, the range and the gradient of the given rules. Look here at this bar. You will find the difference between the superior point is 41, the next one is 40.75. So the difference is just 0.25. It's the most accurate and accurate because I think you won't be prone to miss pathology between these very neighboring points. But if the difference between the first and the second point is 1 diopter or 1.5 diopter, it could be accepted in the screening for this patient in the start. But if you suspected the patient on this wide scale, please readjust the gradient of the difference between the points, readjust to be narrower, and then capture again to know if there is actual pathology or just suspicion or true or false pathology in this. So look at the bar first before judging the map. So the range could be 0.25, could be 0.05. Here, look here, this is 0.25, and here there is 0.5. And down here you will find it wider. Yeah, 1.5, and so you will find that the color coding will be warmer and will be more friendly while the gap is large. Also, the color coding, you know that the red color is the enemy color and the green is your friend all the time. So the color coding will give you an idea about the general impression about the map, and then check the numerical values for these points and correlate. Finally, here the normalized, the scaling of the maps, normalized or absolute, which one is better for your patient? The relative or normalized is individualized to the measured cornea, so it's specific for this patient. But the absolute or standardized scale is recommended in the keratoconus diagnosis as a screening, but you can change again on detection of a suspicious patient from the absolute to the normalized to be more sure, okay? So you have to check all of these before judging. So the tight color, I told you the tight color and lax color and the enemy and friends. What about the typical maps and the anterior curvature map? You'll find the typical maps is either spherical or astigmatic cornea. So in the spherical cornea, you'll find this very smooth and homogeneous map. The all values the same all around. So it's spherical cornea. There is no bow tie. There is no difference. There is no astigmatism in such a case. And here the other example, which is the bow tie. Superior and inferior limbs of the bow tie, you'll find them very unique and very smooth, like the normal bow tie. So no worry, because the central 3 millimeter, showing here the numbers as you see, it's 41.5 and 41.6. Also the same. This is the optimal. There's the central 5 millimeter, 41.4, and here 40.8. There is no steepening here, so no worry. But the bow tie is still the bow tie is still symmetrical and vertical, with the rule astigmatism and normal pattern. And here you will find the same in the central 5, 43.4, 43.5. Both are the same. So whatever the color, either green, because it's somewhat flatter cornea than steeper cornea here, but the numbers are the same, superior and inferior all around. Be still assured about this presentation, and I will finish with this atypical maps. When you have any atypical maps, ask again about the qualification and the acceptance and reliability of these maps to check about the acquisition, misalignment, and large angle cover. To be sure that the atypicality in these maps are true or false. And these are different forms of the atypical maps, either inferior steepening, superior steepening, skewing. The different forms, as you see here, like the inferior steepening with thinning, like in the pellucid marginal degeneration, and measure the angle between the superior limb and the inferior limb if there is a significant angle, and I think the values are well known. And thank you so much.